Even before the COVID-19 pandemic, 1 in 5 Americans was affected by a psychiatric or substance use disorder. Yet less than half receive treatment for behavioral health disorders. Since the onset of the pandemic, we've seen an increase in stress, anxiety, depression, substance use, and elevated numbers of suicidal ideation. With an existing shortage of behavioral health clinicians and an increase in the need for mental health treatment, integration of physical and behavioral health services can be one of the answers to this problem. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle, Executive Speechwriter with AHA. In this podcast, Rebecca Chickie, Senior Director of Behavioral Health Services at the AHA, speaks with Shane McGuire, CEO of Columbia County Health System in Dayton, Washington. Shane has been leading the local hospital district's collaborative work with the University of Washington's psychiatry program and its Advancing Integrated Mental Health Center. The center's primary focus is creating collaborative care models between primary care providers and their mental health care counterparts. This work is changing how Dayton, Washington, population 2,500, brings mental health care to their rural community.
Thank you, Tom, and welcome, Shane, and thank you for your willingness to share your journey to improve access to behavioral health services in the rural Washington community by integrating physical and behavioral health services.
Thank you for having us here to talk about the rural story.
So I know you have a lot to tell us. Let's start at the beginning. Why did you start on your journey to integrate physical and behavioral health?
It's interesting. We started focusing on integration about the same time we joined the Accountable Care Organization. One of the aspects of the ACO, as they're called, is screening with a focus on screening for behavioral health diagnosis. The screening tools are often PHQ-9 or GAD-7. And we started the screening and we found that over 30% of our Medicare population was screening or diagnosing with depression at various levels. And it's sort of eye-opening when you weren't asking the question to begin with, and then all of a sudden you find out that 30% of your population, of the Medicare population, is screening as depressed or having anxiety at an acute level, at a level that needs to be addressed. And then you start asking yourself, where do I send that patient? Because there's no resources in our community. There were no mental health or behavioral health resources within the clinic. And the wait time was an average of 3 months for adults and 7 months for children to get them into resources outside of our area. So that was kind of the first eye-opening experience to say we may need to be doing something about this. And I think there's been some studies that have said that screening in absence of a plan is actually worse than not screening at all, because now you've identified it, but now you're really saying, I guess we have to ignore it or I can't get you into a resource to do something about it. The next thing is about the same time we joined the ACO in 2016, County Health Rankings came out and said that Columbia County has a 570 to 1 ratio of patients to healthcare behavioral health specialists. The state average is 380 to 1. So we not only sort of uncovered this demand, but then we uncovered the fact that we had no real specialists to help us deal with it. And then we lastly looked at our patient panel in the clinic total, which is about 4,500 people. And 1,205 behavioral health diagnoses within that 4,500 people. And again, no way to really deal with it. And you just can't stumble into that and then not do something about it. And so that's really what became the motivating factor.
That's incredible. And I know that a lot of people listening to this podcast are probably on a similar discovery journey right now. And so I'm going to ask you, given all of that, where did you start on the journey? What was your first step?
I'm going to sort of expose some scars on the knees from falling down here, but we immediately said, we got to do something about this. We started putting some feelers out and we had a psychiatrist approach us and said, yeah, I'd love to come work for you. And without knowing anything about what the real needs were or how these different professions interact with your population, we brought a psychiatrist on board. Most of the psychiatrist's work is in the medication side, is in ruling out other medical issues. And it really wasn't addressing anything with regards to counseling. And so, we were getting increased diagnosis, we were getting some medication management, but we weren't really satisfying the whole problem. And then additionally, we found out that we were more co-located then integrated. I mean, he sort of moved his private practice into our facility and kept running as a private practice in our facility. And that's not really what we were looking for either. We were looking for the ability of any one of our providers to walk across a hallway and say, hey, I got this patient in my room and this is what's going on. What are your recommendations? Or can I make an introduction? So that's really, collaborative care. And so our first run at it was not graceful, and it had a lot to do with not knowing what we didn't know. We hired about 9 months later our first LICSW, which is a licensed social worker, clinical social worker. They come sort of ready set with a number of hours in a clinical setting, and really began integrating our care and actually addressing some of the needs for counseling and all the tools that they bring. About 9 months after that, we hired our second LICSW. And at some point in time, the psychiatrist and the organization realized that this just wasn't really working here. We reached out to University of Washington and said, here's our challenge. Here's what we'd like to do. They also acknowledged that having one psychiatrist in a small rural health setting doesn't make sense. The way they use their resources is one psychiatrist can help many rural facilities in sort of a consultative or peer-to-peer basis. So you can actually see within that first 2 years between 2016 and 2018, there are already fits and starts on the journey. And it's just been a growth thing for all of us, to be honest.
There were so many things I wanted to pick up on there that you just said, one of which is, to reinforce this point, the difference between co-located and integrated. That is key. I think a lot of individuals and organizations have tried to be co-located and think that that's going to naturally drive it to integration. But the walls and the barriers, whether they're physical or just procedural, often are still there and still present. So that may have been one of the reasons, and I want to call out the University of Washington here, the Ames Center and the Impact Study. To anyone listening, you can Google either one of those, and a wealth of information on integration of physical and behavioral health related to the work at the University of Washington will come up. They too will reinforce what you just articulated, that true integration takes another level of collaboration and work. All of this does seem like a lot of work, though, Sean. Tell me, is this a financially viable initiative? And I have a second part to that question. Can you also share with us what the COVID pandemic has and will mean for this work going forward?
Yeah, the first part of your question, as reimbursement is structured currently, it's not necessarily financially feasible unless there's some changes. When you talk about fee for service, someone presents with the need, you book them into an appointment, you bring them into somebody, you see them, and then you bill that occurrence. As we're talking about collaborative care, or as we're talking about integrated care models, how do you bill for grabbing your LICSW in his office and making an introduction to a patient that's there for their primary care, and the time that they're going to spend in that office with that patient at that moment? You can't, because it's not the primary reason that patient is there. They were there for a primary care need. True integration is dynamic, it's on demand, it's flexible, and it's everything that scheduled care is not. So, I think that we have some overhauling to do in the reimbursement methodology. I think the chronic care management codes, the CCM codes, and the COCM, which is the coordination of care, are helpful, but I think they're very complex and they're hard to get your hands around and be efficient about billing and getting reimbursed. And so to a certain extent, as an organization, we're carrying this program along as a population health effort. We're bringing it along as a rural health clinic, which offers some cost-based reimbursement methodology. But I think it's going to be tough unless we get additional legislative support and flexibility in how we bill for behavioral health or true integrated behavioral health services. And I guess lastly, COVID really turned all outpatient centers sort of upside down. What do you do about bringing otherwise physically healthy people into a clinic setting for a behavioral health and potentially expose them to COVID? It didn't make any sense. And so transitioning to some sort of telehealth-based methodology for those visits was absolutely necessary to keep both provider and patient safe. But the reimbursement methodology there, again, is challenging since it's not a like-for-like billing service. You just got a reduced fee structure or reimbursement structure for telehealth visits. And so I definitely think COVID had a large impact on integrated models of care. On the other side of the coin, I think COVID helped us become better at what we do and creating more access options. And it'll be interesting to see if reimbursement catches up. I mean, we're seeing a lot of states sort of address telehealth or telecommunications reimbursements in their legislative process. So there is hope that this now becomes just another tool in our toolbox.
Again, there was so much there to unpack. Let me do just a couple of things. I certainly hear you. The collaborative care codes and AHA was part of that work, helping create those for the Medicare program, but it's only a start on the journey. We know from a variety of studies, from Intermountain to Cherokee to a couple of studies actually that the American Psychiatric Association and Milliman have put out, that when you really integrate care, it can improve outcomes and really, truly reduce the overall total cost of care. We've got to build on the foundation that we've made and collect more information to support AHA's advocacy work to advance true reimbursement for truly integrated care. So please know that that's top of our priority. And just a plug for one of the things we're working on with our advocacy agenda now, all of the telehealth waivers that we've experienced that have allowed us to pivot and be responsive to the demands and the needs. That's something that we are continuing to work with the administration and Congress on to try to get those to be more of our future reality.
If you'd allow me, that work is so important that you're doing, because what's happening in the integrated behavioral health model is you're sort of reducing service lines that have predictable payment methodologies. When you engage in somebody who has high anxiety or depression, they may be self-medicating, the anxiety may be driving visits to the emergency department. And so what you've got there is an alignment of care and reimbursement. And so you engage heavily with behavioral health teams, with community health workers, and you actually reduce those volumes into those known revenue producing areas. But there is no revenue code for community health worker engagement. And without having clear alignment in the behavioral health area of service, what we're really doing is misaligning our business and providing services that aren't compensated for. It is better care. It is something that this organization is not going to shy away from. But right now, what we acknowledge is we're getting reimbursement misalignment. It's a good thing, but I would say we have to look at it as transitional. Some people have called it the shaky bridge that you get out there over a river on, because you've really put these services in advance of reimbursement methodologies. And what's going to happen? Will those reimbursements catch up before you sort of hit that tipping point of no longer being able to sustain the services because there is no direct reimbursement line? And currently the largest benefactors of this are the insurance companies and the MCOs and the large organizations, because they actually are still collecting high premiums. We're actually reducing cost of care, but we're not the benefactors of that reduction. And in a rural setting, there is no real such thing as shared savings. I mean, you're never going to get a large insurer come to your organization and offer you a shared savings program for a really small panel of patients. So we need sort of holistic change, and we really appreciate the AHA support on anything you can do to realign reimbursement.
Well, we are continuing to work on it. And I know, like you, sometimes you feel like you're pushing a big rock up the hill, but there's a whole lot of us behind that big rock. So we will eventually make it to the top. And appreciate you being out on that shaky bridge. I love that analogy. I'm going to borrow that if I may. Being out on that shaky bridge and putting the patients first, right? But we've got to have the reimbursement catch up. Given what you've described regarding financial stability and the realistic challenges that creates, can you share some of the key success elements that you see in this work? And how do you measure it? How does this differ from how, when you've rolled out other service lines, how does that differ, or how is it the same?
I think that's been the biggest challenge, because there is so much anecdotal and qualitative support for the work. You can ask a patient, do you feel better? Is this valuable to you? And they will absolutely say all the right things. Yes, thank you. Thank you for being here. But then when you start measuring success using PHQ-9s or measuring tools, and you realize that depression and mental health diagnosis is not linear, and I have a problem and I went in and I talked to somebody and now my problem's gone, and that's reflected in a score somehow. There are steps forward and steps back along behavioral health and mental health journeys. And so you measure over a period of a year, and you get variability in the depression scores. And maybe there's certain seasons that are tougher for individuals than other. Maybe you're one of those individuals that gets depressed around Christmas. And so you go back and you look at your average PHQ-9 on a patient you've done a lot of work with, and you don't see a lot of improvement sometimes. And so what does success look like? I mean, if the patient says this is helping me and they can articulate that, there's definitely value in that. But I think what we're doing right now as an organization is stepping back and saying, are there other ways to measure this different from the tools that we have? I think the other thing that we have to acknowledge in rural is integrated care models, oftentimes based in urban centers, are short intervention cycles. You screen in, you determine that you need to have a couple of appointments with someone, they work with you, they get you sort of righted, and then you go back out healthy on your way. In rural, what we're finding is lots of PTSD, lots of traumatic childhood events in people's lives. And so our counselors, instead of being available for rapid cycle engagements, are building panels of truly sick, chronic behavioral health patients. And again, in an urban center, you may refer that patient out for longer term care, but in a rural setting, there is no one to refer those patients out to. And those patients are the ones that are making measurements of success difficult. And so right now we're talking about maybe we repanelize these so that the chronically ill are separate from the short intervention cycles, so we don't deprive ourselves of the success that we can achieve with short interventions by kind of overshadowing them with a heavy chronically ill roster. So, the University of Washington could tell you that this is a question that I've been asking their providers. They're academics, they think like this. What does success look like in general? How do we measure it? But what does success in rural look like? And how do we deal with some of those more intrinsic challenges in rural?
It's never easy. What is the old saying? If it were easy, everybody would be doing it. So,
yeah. But the work is so rewarding. That's the thing, is that even one patient in a complex panel that had suicidal ideology and all of a sudden isn't, it just makes the work so worth it. So, and it makes you want to do that more. How do I repeat that success?
Well, before I launch on our last two questions, I wanted to just reiterate a statistic that's relevant to all of what you've said. I think the statistic is that 70% of individuals with severe chronic mental illness also have a comorbid physical condition. So looking at it from the standpoint of how can we improve their diabetes, how can we improve their cardiac care, how can we reduce the symptoms of congestive heart failure, the work that you're doing not only can help address their chronic depression, their PTSD, but it's also been shown to impact and improve the quality of their overall physical life.
Yeah, definitely. I mean, there's 2 points that you made there. For chronically depressed individuals, most people that attempt suicide have actually had a visit with their primary care doctor within 4-week period of time before that attempt. And so right there is a case for integration, because the primary care doc and the tools and the screenings will allow us to catch that individual and maybe get them some help sooner. But I always talk about like the interplay of diabetes. Like, am I depressed because I'm on this restricted diet and I have this disease I can't get rid of? Or am I self-medicating with food that's exacerbating my diabetes? There's so much interplay between chronic disease and mental health and our mental state. Smoking, substance use disorder, many of those things are often tied to some sort of chronic debilitating illness that you really can't change, which leads to the depression and the self-medicating. And that's the intervention that we're highly focused on right now. We want to risk stratify our patients into panels to say, what is the interplay between behavioral health and their chronic disease? We just were awarded, and I'm announcing it sort of on this podcast, we were one of 15 awardees for a HRSA grant, a $1.2 million HRSA grant. We're the only hospital in Washington state that actually was able to receive that grant. And it's because of this work. It is focused on chronic disease states, but it's because of our integrated model that we're able to say, this is how we're going to make some inroad on these individuals. And so we're very happy about receiving that grant, but we know it's because we're an integrated model of care that we were able to sort of pitch and tell the people reviewing the grant, this is how we're going to approach it. And it resonated. Clearly, it resonated.
Congratulations, and honored to be the platform upon which you make that announcement. Thank you. Just a couple of things. One, you've talked about a number of challenges, reimbursement being one of the biggest, but also just changing culture and workforce. Beyond those, How are you thinking about sustaining this work? What's your next thing that you're tackling to make providing these types of integrated services easier than it was in the beginning or that it might be now?
Yeah, I think the biggest challenge is, first of all, getting them off the ground and finding some sort of support effort, whether that's an ACO or in Washington State, we have what we call the Accountable Communities of Health that have helped pour some funds into rural organizations to build these programs. The problem with all those programs is they have a timeline, like they exist for 3 years or 4 years or 5 years, and then you've got to be sort of self-standing. I would argue, though, that we've got to start thinking of it as just healthcare and not saying, well, this is behavioral health care and this is primary care, this is specialty care. It really is just healthcare. It's the same thing with oral health. We're in the process right now of building a dental clinic on our rural healthcare clinic. I think we'll be one of 3 in Washington State. And the FQHCs have been doing this for a very long time. But when did we separate the mouth and the brain from the overall body? It doesn't make any sense. Let's put a whole person back together and treat a whole person. And so what really struck me is I talked to one of our LICSWs who had never been part of an integrated model of care. And I said, well, what do you think? And she said, I can never imagine myself not practicing in an integrated model of care. And so when you look at it from that perspective and you realize how important and intrinsic it is, you can no longer look at that service line as, hey, you can dispose of this, or this is a dispensable service. It is a service you absolutely have to have, and you have to integrate it into your total cost of operations. And there may not always be reimbursement alignment, but it is the right thing to do. And there are other methods to find support for those types of things. We do it all the time in healthcare. You offset maybe underperforming service line or a service line that's required of you that isn't got reimbursement to support it with other service lines that do. And that's how we're looking at behavioral health. We don't anticipate ever separating it from our existing service lines. In fact, we're looking at ways to expand it throughout the entire health system. I would say that's sort of the next step. This isn't just an outpatient clinic thing. The patients that we see in our hospital beds or our swing beds or in our physical therapy department, they're the same patients. Where does the chronic pain patient that's getting PT for their chronic pain, and all of a sudden you uncover, some traumatic experience they had as a child that's actually the root cause of that chronic pain? How do you get your behavioral health worker into that physical therapy setting to start working with that patient? If you've got a patient that's in your swing bed who's got substance use disorder and they're in your bed because they have endocarditis, and all you're doing is providing IV antibiotics, you're not doing anything to address that underlying root cause. You've got to start talking about the addiction while they're in your hospital bed. If they're going to be there for 100 days with an infectious disease doc managing their infection, you've got 100 days to do some really good work on a captive audience, and an audience that for the first time is probably clean and sober. So we need to actually push behavioral health integration past clinics and into health systems.
Shane, thank you.
Yeah, and thank you for advocating for us. These programs wouldn't be possible without good, strong advocacy, legislative advocacy, reimbursement advocacy. We really appreciate the support the AHA provides that University of Washington's provided as well. So, and thank you for giving me a megaphone to talk about this, because I do think it's important work nationally.
You are such an inspiration, and the work that you're doing is truly on the leading edge. Thank you to you for the work that you're doing in your community, for the patients you serve, and for taking the time with us today to really share and inspire others to do this important work.
To learn more about the work being done to support hospitals in improving access to behavioral health services, please visit aha.org/behavioral health.